Welcome everyone, and the question is: a 25-year-old girl present in OPD complaining of infrequent periods with weight gain and hirsutism. What would be the steps of the management for the patient? Now here look at the triad. The triad include hirsutism, amenorrhea, and androgen increase. So this is triad for polycystic ovarian syndrome. In polycystic ovarian syndrome, what happens? There arises multiple cysts in the ovaries, and patient present with a subfertility. So that subfertility is caused by polycystic ovarian syndrome. So the treatment for polycystic ovarian syndrome will be history. First of all, we take the history from the patient, then examine and uh, look at the hair distribution. Galactorrhea occurs in the patient, hyperpigmentation, acne will be there. Investigations will be ultrasonography, hormonal profile shows androgens will be increased, prolactin will be increased, FSH, LH will be increased, testosterone, and a treatment plan with will be weight reduction because it occurs in because of obesity. Cosmetic measures should be given. Medical treatment will be metformin and donazolone, and surgical treatment can be done in the polycystic ovarian syndrome, as we indicate that it is a disease in which there arises multiple cysts, and it presents with the triad of hirsutism, increased androgen, and subfertility. Amenorrhea and subfertility occurs, and acne will be there. Patient will have abnormal color spots on the body, and hirsutism, excessive growth of facial hair, will be there in the patient in polycystic ovarian syndrome. It is associated with obesity, so in treatment, patient should be prescribed to weight reduction. Reduction of the weight can help in minimizing the symptoms of polycystic ovarian syndrome. Welcome everyone. So the question is: a 30-year-old para present in OPD with a history of curdy discharge, thick vaginal discharge, pruritus, and vulvar soreness. What is most important diagnosis and what will be the management? Now here question says that the patient has curdy thick vaginal discharge. Curdy thick vaginal discharge is indicative of vaginal candidiasis. Curdy discharge is indication for vaginal candidiasis, and the management for vaginal candidiasis will be advise the patient for personal hygiene and undercloth hygiene maintenance. Treat the partner with antifungal, local and systemic antifungals, and follow up to treat the recurrence. So in this way, vaginal candidiasis can be treated. Its presentation is a thick curdy vaginal discharge. Thick curdy vaginal discharge is vaginal candidiasis. Welcome everyone in gynecology MCQ series, and the question is: a primigravida in second stage of labor. For the past 2 hours, fetal head is at first station in spite of ineffective uterine contraction. Mother is unable to push. She is exhausted. What is most next step for the management? So the next step is instrumental delivery, because mother has been exhausted and effort she cannot put effort in delivery, so instrumental delivery is best preferred. Another question is: maximum normal time for second stage of labor in primigravida without anesthesia. What is maximum time? That is 120 minutes. 120 minutes is the second normal time for second stage of labor. Another question is: crowning is best defined as. The answer is when perineum bulges in front of fetal head. Perineum bulges in front of fetal head. What happens when fetal head is delivered first? Then that condition is known as crowning. So when fetal head comes first through perineum, that condition is known as crowning, or the perineum bulges through fetal head. Total Bishop score is 13. Another question is the pregnancy-induced hypertension is diagnosed when there is hypertension is encountered after 20 weeks of gestation. Hypertension is encountered after 20 weeks of gestation. That condition is known as hypertension, pregnancy-induced hypertension or preeclampsia. Thyrotoxicosis in pregnancy is treated with, the answer is neomercazole. Neomercazole is the treatment for thyrotoxicosis in pregnancy. Now, here one thing should be noted that radioactive ablation is not given in thyroid disease in pregnancy, and the surgery cannot be done without iodine drops. Beta blockers should not be given. Partial thyroidectomy is not preferred choice, so the treatment will be neomercazole is the treatment.